G'day everyone, my name is Gihan. I'm one of the radiologists from South Coast Radiology. And I don't have a lot of time with you unfortunately today, but I thought I'd just cover very quickly how we do a shoulder ultrasound. So when you send that referral through to us, what actually happens at the radiology department when the patient comes through. So we've got Ash here, one of our sonographers, who'll be helping us with the shoulder ultrasound. So what I'll do is I'll just quickly recap shoulder anatomy. This is not an exhaustive sort of lecture on anatomy, but essentially you've got, have I got a pointer by any chance? I'll just use this here, yeah. So we've got, this is just a coronal cross section. So you've got supraspinatus coming in here, and then the bursa is just sitting on top of that. So the bursa sits between the supraspinatus and the deltoid, as well as the supraspinatus and the acromion here. So that's kind of the area that we're going to focus on. So what we'll do is we'll get the ultrasound machine set up. And in the meantime, any volunteers with healthy shoulders? Sure. So now, the first thing we start looking at is that round structure there is the long-headed biceps tendon in cross-section. Do I have a pointer by any chance? No. No, okay. So I'll just point my fingers. That's long-headed biceps there in trans, and Ash, if we can show that in long as well. So that's lengthwise, which we call long. So you can see the nice fibers of the long-headed biceps tendon. Sorry, Linda, you can't see this. Oh, you got the screen. Yeah, you got the screen there. Perfect. Okay, so we make sure that's intact. We look for fluid around that tendon. If you're seeing a lot of fluid and synovitis, that might be an indication that there might be long-headed biceps tenosynovitis. So we'll then go on to the rotator cuff now. So the first tendon that we look at is so this is subscap here coming across. Just to orient you, this is humerus, this is bone here. Got some fat, subcutaneous fat, and this looks like deltoid muscle on top. That's subscapularis tendon coming into view there in long. We can look at that in trans as well, and that's in trans, so in cross section looking at it. So that's a normal appearance of a subscap. We'll go to supra now, and just while you're looking at the screen, just pay attention to how Ash is doing the motions of the shoulder as well. So to bring these tendons into view, you got to basically abduct the shoulder, bring the supraspinatus into view. So one of the things that's really important to make sure is that your patient has the mobility to be able to do that, so we can actually see the tendons. So a lot of the time, if patients are coming in with, say, adhesive capsulitis, they've got such poor movement that we just can't see the tendons at all. So, so just something to be aware of. This is. Yeah.
So if someone's got acute capsulitis, is ultrasound a useful modality?
Exactly. So I think it depends on what their range of motion is. Like if you look, and the question being asked, if you're asking, is there a complete cuff tear or something like that, we can just get in and see something, and we can see that the cuff is completely gone. Yeah. But if you're looking for subtle things, then it's going to be hard. If you're looking for things like bursal impingement, that might be quite hard to do. So it and again depends on how restricted their motion is. So if they can't move it at all and they're just sort of stuck in that position, then there's not much we can do.
So really, I think it's a really good point. It's
yeah.
Not really, because frozen shoulders are either primary or secondary.
Yeah.
So the reason we're sending them for an ultrasound or MRI is to determine whether or not there's a secondary cause, such as a cuff tear.
Yeah.
So really, they're best to get an MRI scan to determine that.
Yeah, I think so.
Otherwise, it's a clinical diagnosis.
Yes.
It's based on history examination.
Yeah, that's right.
Frozen shoulder.
Yeah.
Trying to rule out a cuff tear, probably the best thing is MRI scan.
Yeah.
For the patient, if you think clinically they've got they're looking at
that's fair.
A cuff tear.
Yeah.
Cost difference, Gia?
Cost difference. I don't know. I think I'd look at the. Yeah, it's about and I don't know if there's I think there's no rebate if it's referred.
So the best thing is examine your patients, examine their cuff.
Yeah.
It's presenting like a primary frozen shoulder in a 40 to 60-year-old patient with gradual onset of pain, no history of trauma.
Yeah.
You examine their cuff, they've got a strong cuff. You don't need anything else.
Yeah. So I think that point is valid for like clear-cut capsulitis, and sometimes it can be quite difficult to differentiate between capsulitis and, so say, bursal impingement. So one of the things I always do is when I see a patient, I always do a clinical exam, just a quick, external rotation, internal rotation test, see what their range of motion is for that side vis-a-vis the other side. And then one of the things that we've actually seen sometimes with ultrasound is we've seen that there are certain things we can actually look for of capsulitis on ultrasound as well. Things like looking at vascularity in the axillary recess, but again, to do that, you've got to be able to get the probe into that space. So And there's this other thing called blocking. So we'll show you what impingement looks like, where the bursa impinges as you abduct. And sometimes you get this thing where you don't see any impingement, but suddenly they kind of get to that point and it feels like this wooden feeling, like you're hitting wood. And that's a very classic sign of capsulitis. And we can see that quite well on ultrasound. So we'll keep going. So this is supraspinatus. Looking at it in trans, and you can see nice sort of smooth tendon outline. You can see this line is parallel. That's the bursal surface there, articular surface here. This dark line is cartilage that's sitting on top of the humeral head. So that's supraspinatus in trans, and did we look at it in long? Just quickly show them in long what it looks like. So you can see the supraspinatus coming in and attaching at the supraspinatus foot plate right here. So that's a beautiful supraspinatus tendon. Look at these echoes here. So these like lines that you're seeing that are parallel, we'll call it the laminar appearance. You can see that quite well there. That's a normal healthy tendon. And when you lose that and it becomes hypoechoic, and I've got some pictures to show you, that's tendinopathy. So that's a nice healthy tendon there. And keep going. So now we're going to look at infraspinatus and teres minor, which are kind of at the back. So you've got to bring the shoulder across like that. So we're starting off with this very thin, slender tendon here at the bottom, which is your teres minor. So it looks like it's coming in from, how are you scanning that?
It's coming in
from the left of the screen?
no, it's coming on from the other side.
Okay, so yeah, so tendon's coming in from this side and attaching around here. It's a bit hard to see that one, so that's teres minor. And then if you go just above that, that's infraspinatus right there, again with that. So you can appreciate all of these tendons look the same. So you really need to know the motion, and also you need to have a label to understand. If I just looked at this picture, I wouldn't know this from the shoulder, from the foot. So that's the rotator cuff. Any questions on the rotator cuff so far? Might just move on to impingement then. So subacromial impingement is really common. We see it all the time in the community. So we can diagnose it really well on ultrasound. And in some ways it can be a bit better than MRI because it's dynamic. So this is a acromion bone here. This is supraspinatus tendon. You can see that moving and sliding along. And the interface between, if you just come back to the tendon, the interface between the tendon and that's deltoid over there, that interface is the bursa. So this is a nice thin bursa. When in impingement you can see it quite thick and quite heterogeneous. So this is a nice bursa, and I'll show you a video of what impingement looks like, but can we show that the view of the coracoacromial ligament?
This one,
Yeah, it's a bit nicer. So this is, again, looking at supraspinatus, and it's, as we abduct the shoulder, let's see if we can clear that up a bit more. You can see that nice sliding action happening here, so that's the bursa. And in impingement, you see this bursa bunching up, and sometimes you can see the tendon bunching up as well. So that's how we diagnose impingement. Yeah, exactly. And sometimes when we don't know where the bursa is, I use that motion to know exactly where the bursa is, because the bursa is essentially what's allowing that movement. And when we do your bursal injections, that's the space that we inject into. And then we move on to the AC joint.
AC?
Yep. So that's the normal AC joint. You've got clavicle, looks like, on that side, and acromion on this side. That's a normal joint. Sometimes you see lots of irregularity and bone irregularity. That could be an indication of AC joint arthropathy. You can see capsular thickening, which is not the case here. It's a nice, beautiful AC joint. Does anyone have any sort of pathologic shoulders that wouldn't mind us having a look? If not, we can move on. Oh, have you got okay. Yeah. Do you know? We'll try and diagnose you. Don't tell us what you've got.
Dicky shoulder. Dicky shoulder.
And what treatment did you have?
Injections and lots of antibiotics because it's too near a nerve for us to operate.
So we'll jump in straight for the ultrasound, but normally what I would do is I'd check their motion first. I'll do external rotation, internal rotation, and also do the empty can test. I mean, that's my little the empty can test. Look for impingement. And then what else do? I do arms all the way up like this. So usually what you find is that when in subacromial impingement, they'll stop about here, which is the painful arc, and they can keep going on this side. And then once you hold them up past the painful arc, they're okay up here. which is not what you see in capsulitis. They're kind of there and then they're stuck. Yeah, yeah.
And so that could be either subacromial bursitis or a tear.
When they have the subacromial, when that painful arc, that's an indication of subacromial impingement. There may or may not be a tear, but generally that's the classic sort of painful arc is what you get with bursitis, with impingement. Impingement and bursitis are used sort of interchangeably. I guess that's okay. I think that's okay to do, but technically it's subacromial impingement, which then becomes inflamed and becomes bursitis. So they're technically two different things. But anyway, subacromial bursitis and subacromial impingement, I use them interchangeably most of the time. And another test that we can do in radiology, which I'll talk about as well, is if you're really struggling to differentiate between capsulitis and impingement, we can actually put a bit of local anaesthetic into the subacromial space. Give it a bit of corticosteroid as well. Do that impingement test, so do the range of motion test and demonstrate the painful arc before the injection, and then after the injection they're magically better. So that way you know that it's the bursa that was the culprit.
And sometimes you can do bursitis without the tear, can't you?
Yep, absolutely. So I'll talk about the different types of bursal. So you can have primary bursitis and then you can have secondary bursitis. So subacromial impingement mainly is a pathology where there's just not enough space in that subacromial space for the tendon to glide, to move. And as a result of that, over time you can get tears off the rotator cuff. So that's one mechanism, one way by which you can get tears. But I'll talk about that after. So we'll quickly have a look at, I'm sorry, I didn't catch your name. Mandy's shoulder. So we'll start off with the long-headed biceps real quick. That looks like it's intact. Yep, we can see some fibers through there. Mind you, this is not a great machine. This is not a diagnostic quality machine. It's just more suited for portability rather than accuracy. And you can see some nice fibers of the long-headed biceps here. Sorry, yep, that's right. Yep, and we'll move on to the cuff. So we're going to have a look at subscap first. So there's subscap coming into view. That looks pretty normal to me, those fibers there. Where are the calcifications? Yeah, I think there might be a little calcification there, but that looks like enthesopathy to me rather than calcific tendonitis, which I'll talk about the difference as well. Let's keep going. So now we're going to look at supraspinatus. Now that supraspinatus looks a little bit thick and a little bit hypoechoic to me. What does it look like in long? It is a little bit bulky. It's not terrible, but it's looking a little bit bulky. And see this bursa here? It's looking a little bit thick there. It is a bit subjective, and sometimes if I'm not sure, what I'll do is I'll compare with the other shoulder in real time as well. But just from my experience, this looks a little bit thick and a little bit tendinopathic. I'd say mild though. We're not seeing any gross tears at this stage, are we? Yeah, this is just a very quick, that's fine. Yeah. And we'll go into teres and infra.
It's so hard to read ultrasounds when you haven't done them.
Yes, yeah, it does take a bit of experience and you need a bit of mileage for your eyes as well to know what you're looking at. The main thing with ultrasound is also orienting, because when I was first starting reading ultrasound, I think the thing that I struggle the most is orienting to the structures, like knowing this is the surface here, this is subcutaneous fat. I think that's subcutaneous fat, and you've got deltoid, and you've got your rotator cuff. So that's deltoid here. This is cuff here. This is bone. So that looks like a normal teres minor. Yep, and then infra. That also looks a bit thick to me. Yep, that looks a bit hypoechoic, and there's some calcification here, but those are, I think that's enthesopathy, which is basically enthesopathy is tendon comes and attaches to bone, and over time with traction you get sort of calcific proliferation at the interface of the tendon and the bone. We call that enthesopathy. So you can see that quite well in ultrasound, and a lot of people call that calcific tendonitis, which is not the case. Calcific tendonitis is a very specific entity, which I'll talk about in a bit. So this to me looks like a shoulder that might have had a bit of chronic subacromial impingement, with tendinopathy that's occurring in the infra and the supra as a result of that. So what about impingement? Are we seeing any impingement there? So we're just getting into the view. So, so this is acromion here, and a lot of the impingement tends to happen under the acromion. As the tendon tries to slide under this bony structure, it gets impinged. How are we going? Yep, that's coracoacromial ligament. Yeah, I think that tendon is trying to bunch a bit, but it's a bit hard to stabilize the probe. Just go smooth motion as you stay into that position. See how the tendon's changing shape as you get to the very top? Just keep going up. Right there, it's sort of changing morphology. It's a bit hard to see that because the picture is moving as well. But this tendon is trying to impinge, and that bursa, I think, is trying to impinge as well. So I would say Mandy probably has a bit of subacromial bursal impingement, and as a result of that, she probably has a bit of supraspinatus and, to a lesser extent, infraspinatus tendinopathy. But we can't see any tears yet. But if she keeps impinging like that over time, she may well end up with some tears.
Is that because those parts of the rotating cuff are trying to pull a little bit harder to try and get them past the
So why impingement happens? So we'll talk about the reasons. There's primary and then there's secondary. So primary is when there is an anatomical abnormality. For example, the shape of the acromion. So most of us will have a type 2. I've got some pictures here. I might just flick over and I'll unless you've found anything else to add. Ash? No. Thank you so much, Maddie. And thank you to Linda as well. Okay, might just go through the slides and I'll get to subacromial impingement. So this is a classic cuff tear. You can see before we saw that nice trilaminar appearance, here we've got this defect. It's hypoechoic, it's filled with fluid and gunk. So this is a high-grade supraspinatus tear. This is another cuff tear. Looks like it's chronic because a lot of that fluid's gone. So here's the bursal surface up here. And here is supposed to be where the tendon's supposed to be. That's all gone and retracted. So this is a complete supraspinatus tear. This is what tendinopathy looked like. I talked about that trilaminar appearance. You can see this hypoechoic area. We don't see those nice echogenic lines that I showed you before. So this is classic tendinosis or tendinopathy. Just a quick word on how to describe tears. So you'll see in a lot of the reports there's words like complete tear, incomplete tear, partial thickness, full thickness. What does it all mean? Okay, so complete tear is easy. You've got a tendon and it's completely torn and it's retracted. So that's a complete tear. The muscle pulls on the tendon. So often with a complete tear, you just won't see the tendon at all. It just kind of goes back towards the medially. And then you can divide partial tears into bursal surface, which is up here, or articular surface, which is down here. So that's articular surface because that's where the joint side is, and bursal surface because that's where the bursal side is. So partial thickness bursal, partial thickness articular. And then you can have an intrasubstance tear, which is within the tendon substance itself, where the bursal surface fibers and the articular surface fibers are actually intact around the tear. So those are the kind of main descriptors, okay? Now, I always get asked, what does a full thickness tear mean? Does that mean that it's completely torn or partially torn? So full thickness tear means that we're looking at the width of the tear. So it'd be something like this in cross-sectional view. So you've got tendon fibers on either side. So it's partial width, but full thickness. Okay, so it's involving both it's extending from the bursal surface all the way to the articular surface, but there's fibers on either side. And then these are just, and we do use descriptors like anterior, mid, posterior. So we might say something like full thickness tear of the supraspinatus anterior fibers. So that means the mid and posterior fibers are intact. Okay, so that's just terminology. This is a quick video showing subacromial impingement, which I don't know if it's going to load. It probably won't, but we saw a nice case of impingement there with Mandy's shoulder, so I'll just skip that one. Okay, so subacromial spur. So you can get bony spurring in the subacromial space. Usually this occurs with where the coracoacromial ligament attaches, and over time it just forms a spur. And it's to do with traction. I think the bone just proliferates as a reaction to that. One of my mentors always used to say, bone's dumb, all it does is grow. So, and I think it's very true. You see that a lot. Like osteophytes are a good example of that. It just kind of reacts by growing. So in this case, it's just reacted to that traction injury by growing into the subacromial space, not realizing that we're actually taking away limited, really valuable space that's there for the rotator cuff. So we can see that quite well on X-rays. Here's another subacromial spur. These are the acromial subtypes that I talked about in primary subacromial impingement. So the number 2, which is that curved surface here, so this is a sagittal view, by the way, sagittal MRI. This is the most common type that all of us would have, and that's considered normal, if you like. You can have a flat undersurface like that. You can have a hook surface like this one here. And then there is this fourth one that's rarely described, and that's called a convex undersurface. So the number 3 and number 4 are highly associated with subacromial impingement and cuff tearing. And so, and the surgeons will talk to you about how they do the acromioplasties and try to make more room under the acromion for those tendons. Just very briefly on AC joint injury. So we use a Rockwood classification. We talk about, the grade 1 is just spraying off the AC joint capsule, and then you progress, as you progress through the grades, you can see tearing of these coracoclavicular ligaments, the coinoid and the trapezoid ligaments. We can see that quite well on the x-rays. This is an example of AC joint degeneration. You can see subchondral sclerosis, osteophytes, and joint space loss, and a bit of vacuum phenomenon. There's actually gas in that joint. And we find that quite commonly with degenerate joints is that they draw in gas from, we think it's because the nitrogen that's dissolved in the blood tends to come out into the joint. No one knows exactly why, but we see that quite commonly. Glenohumeral joint OA, so just showing you severe osteoarthritis of that glenohumeral joint. Okay, so I'll talk a bit about injections, and I think as part of that we'll talk about subacromial bursal impingement a bit more. Okay, so subacromial bursal injections are the most common injections that we do in radiology. A lot of the time we do them as therapeutic, but as I said to you before, we can do it as a diagnostic test where we can examine the shoulder and see that they're impinging in that painful arc, and then put the local in and they're suddenly better. And that's a very good test. I think it's called the NEAR test. It's very good for diagnosing subacromial bursal impingement. We don't do it very often at South Coast, but where I used to work before, I used to do heaps of diagnostic bursal injections. Out of interest, how many of you guys examine, like in terms of after your patients had their bursal injection, do you kind of examine and see if you don't tend to get to do that, do you? Because technically if the bursal injections worked, it's providing, yeah, right, okay, yeah, well that's I suppose helpful, yeah. All right, so then we can do glenohumeral joint injections for OA, but also hydrodilatation, which is for capsulitis. And then AC joint injections, long-headed biceps sheath, we'll talk about barbotage, and intratendon PRP. Okay, so normally with our injections, we infiltrate corticosteroid, and usually we use celestone. We always put in a long-acting local anesthetic, i.e. bupivacaine. And for hydrodilatation, we use normal saline, and PRP we'll talk about briefly. Now, this is a typical ultrasound-guided bursal injection. So here's supraspinatus attaching to the glenoid, the humeral head foot plate, and this is the bursite distending with the fluid that we're injecting. Okay, so as I said to you before, so the primary causes of subacromial bursitis is that the acromial shape, and also if you have those subacromial spurs that I showed you before, that's an anatomical problem with the subacromial space that's causing the impingement. But the other possibility is that there is a functional cause. It might be because of overuse. They've done something, because remember, if you damage the supraspinatus with time, with microtrauma, it tends to be tendinopathic. And with tendinopathy, it actually makes the supraspinatus bigger. And that actually makes the problem worse, because now you've got less space for the supraspinatus to slide through. So it kind of becomes a positive feedback loop. And I think there's the physiotherapist will know more about this, but sometimes like your posture can also make a difference. If you're doing like a lot of overhead work, but if you're kind of slouching, it tends to cause a bit more impingement. Whereas if you're kind of sitting with, proud like that, it tends to disengage that supra from under the acromion, and it gives you a bit more space. So that can be so those are functional causes of subacromial impingement. Does that sort of answer your questions about the different causes of impingement? I think that was what you guys were asking before.
So basically, impingement is a clinical term.
Yes.
It's not a diagnosis. The diagnosis is either subacromial bursitis or that with tears.
Yes. So.
Does that just trying to summarize?
Yeah. Yeah.
It's not a diagnosis.
Yes.
It's a clinical term.
Yes. Yeah. I agree.
Bursitis is a diagnosis.
Yeah.
Rotator cuff tear is a diagnosis.
Yeah. I agree with that.
Nice diagnosis.
Yeah.
It's a clinical syndrome.
And the other thing is on ultrasound, we see asymptomatic patients demonstrate subacromial bursal impingement, but they don't have bursitis, and they don't have any of the symptoms of subacromial syndrome, subacromial impingement syndrome. So most normal people, if you do an ultrasound on them and you do this a few times, you will see that their bursa starts to impinge. But that doesn't mean that they've got the clinical syndrome, which we commonly call subacromial bursitis, if that makes sense. So indications for, now, normally we do subacromial injections for bursal impingement or bursitis. But I have been asked to do them for cuff tendinopathy and partial cuff tears as well. And that's all well and good if it's because of bursal impingement. But I'm not sure, because I mean you can get a traumatic partial cuff tear. So I don't know. Maybe Andrew, you can answer that.
Yeah, I think it's a good option. I think so. If someone's got cuff tendinopathy or a partial tear, and a component of their pain is coming from bursitis,
Yes.
associated with that situation, so that occur in isolation.
Correct. Yeah.
To get them to move forward through a rehabilitation process, we'll often need a single shot of hydrocortisone or cortisone, local anaesthetic, to take away that pain, and to allow them to start retraining with their physios. Otherwise, you're stuck. And there's good evidence that our clinical practice guidelines show that that's safe. So
Yes.
A single shot steroid injection in the context of a partial thickness of a small cuff tear is safe. It's not going to lead to an increased re-tear rate. The problem you have is if you start doing multiple injections.
That's right. Yeah, and that's my understanding as well. Because as you know, when you introduce steroid into a tendinopathic tendon, there is that theoretical risk of increased risk of tear. But if you're just using 1 or 2 injections spaced apart, then that risk is manageable. And we never inject into the tendon. We never inject corticosteroid into a tendon because it will weaken the tendon. It's always into the bursa or the joint. Now, this is just a little note because I get a lot of requests for bursal injections when there is complete tears of the cuff. So if you can imagine, if you have a complete tear of the supra, then your bursa starts to communicate with the joint. So you just have one big space and you can't really discern a distinct bursa from a joint. So in the setting of a complete cuff tear, it's a bit nonsensical to talk about bursal injections. So just an anatomic thing for you guys to be aware of, because I see it all the time. So essentially what we would do in that case is we would be doing a joint injection. Because once there is a complete tear, the cuff is the joint is in communication with the bursa. Okay, so this is just how we do the hydrodilatation. So this is actually how I used to do them, but we don't do them like this anymore. We do it under CT. This is a fluoroscopic guided hydrodilatation. So we just put a needle into the joint, put some contrast in. You can see the contrast outlining the joint space, so we know we're definitely into the joint. And then we put in our normal saline and our corticosteroid and our Marcaine. This is how we do it now at South Coast under CT. It's much quicker. And so, basically needle into, it's the same principle but just a different modality. So glenohumeral joint injections, we can use them for osteoarthritis. If they have labral tears for symptom relief, we can use intra-articular injections, and then hydrodilatation for adhesive capsulitis, as you know. In patients with long-headed biceps tendon tenosynovitis, we do long-headed biceps tendon sheath injections like so. But just keep in mind that the sheath actually does communicate with the joint space, so some of that medication will actually inevitably end up in the joint as well. Indications for, so we talked about that. Barbotage, so calcific tendonitis. Now we talked briefly about enthesopathy. Enthesopathy is that sort of calcium growing or bone growing into the tendon insertion with chronic traction. Acute calcific tendonitis is when, I don't actually know the actual mechanism, but for some reason, in a certain subset of patients, when they undergo a traumatic injury to a cuff tendon, it tends to react by sort of laying down lots of calcium. And you get these big blobs of calcium. And what we do is we do a barbotage where we put a needle into it and we try and aspirate some of that calcium out. And what you draw out is sort of like this toothpaste density material. It looks like it's literally white, and it looks like it's the same consistency as toothpaste. It's very interesting. This is what it would look like on X-ray. And once you do the barbotage, and then following that, we'll put a bit of local anaesthetic and some steroid into the bursal space. It works really well for them. They might need another injection maybe a couple of weeks after, but it sort of pretty much just takes away all their symptoms and they're back to normal. So, but that really only is reserved for acute calcific tendonitis, which is what I just described. So this is the calcific deposit here. Because we get a lot of referrals for barbotage when it's there's chronic calcific tendonitis. Yeah, it's actually chronic calcium deposition. So this is quite a soft deposit of calcium. I can see that because of the way it looks. When it's chronic calcium, it's often shadowing because it's so hard and dense that it's actually like not allowing the ultrasound beam to penetrate through. So in those cases, this is absolutely useless. So I don't even bother because I know I'm not going to get anything out. And a lot of the time, those patients are their pain is not because of that calcium. It's been there for eons. So indications for barbotage has to be acute calcific tendonitis, not indicated for hard calcium. And when they have acute calcific tendonitis, there's a lot of inflammation around that area. You can see that with the Doppler. The Doppler lights up like a Christmas tree. You don't see that with chronic calcium. And as I said to you before, not indicated in enthesopathy. And this is that enthesopathy that I talked about. So these are little formations of calcium or bone that's forming at the interface of the tendon and the bone. And unfortunately, there are some radiologists who have called that calcific tendonitis. Unfortunately, that's resulted in referrals coming through to us for barbotage. So, so it's quite a prevalent thought pattern out there. PRP we don't use very often in the shoulder joint. There is some conflicting evidence. I did a very thorough literature review on PRP and its effectiveness for different targets. And the shoulder didn't come up, and that was in 2019. But since then, I did notice that there was some meta-analysis that came out that showed that maybe there's some evidence for certain conditions. But I think if we are going to look at PRP in the shoulder joint, then these are the targets that I would consider. One, it's a tendinopathic tendon, or there's an intrasubstance or a partial tendon tear. I would not recommend them in full thickness tears because there's nothing really to target once it's complete. And then the other option is if they've got glenohumeral joint or potentially AC joint OA. I don't have a lot of experience with this. I do have experience with injecting into tendinopathic tendons, and unfortunately I can't tell you whether they benefited from it because we never see the patients after. But we do a lot more PRPs into knees and common extensor origins, and I have seen quite good outcomes with those.